Hello, myself Dr. Shailesh Khode, consultant otolaryngologist, sleep apnea surgeon, Abu Dhabi, United Arab Emirates. A drug-induced sleep endoscopy, a guiding tool for the sleep surgeon. It helps us to find out the site of vibration or snoring during sleep. It will also help us to find out what is the reason for CPAP intolerance and poor adherence. To know that is it a single level or multi-level collapse in the upper airway, and what type of collapse is it? It's a lateral, anterolateral, concentric collapse. Is there any change in the collapsibility as per the sleep position? And last but not the least, to decide is this the patient is a good candidate for surgery or not. So it is performed by the flexible nasopharyngo-laryngoscope. It is passed through the nose and we check nasopharynx, oropharynx and hypopharynx. I'm doing the drug-induced sleep endoscopy for this gentleman. I'm standing on the right arm of the patient like a routine flexible endoscopy or the nose surgery. You can see the system. I have a flexible laryngoscope. We usually keep the patient identification point over here just to make sure we are doing the right patient, and that is how we set up the bispectral index, and from there we get the monitoring over here. You can see currently patient BC is 89 and that's the monitor. So we are standing right the patient and we are doing the key maneuvers. One is in the supine position, then by small jaw thrust, and then we turn patient to the right side or the left side, depends on the collapsibility and dynamism of the upper airway. For the documentation, we use vote classification, and as per the collapsibility, we mention it. Is it an anteroposterior, lateral, or concentric collapse? And we can degree of obstruction in terms of no obstruction, partial, or complete obstruction. When you pass the camera through the nose, it is very crucial to also document about the deviated nasal septum and other sinonasal pathology, which is the main factor responsible for difficulty in breathing during night time. And if there is a significant obstruction in the nose, leads to the Bernoulli's phenomena and exacerbate the obstruction downstairs. When we pass the camera and negotiate the posterior choana and we check it at the level of velum, we can get either anteroposterior type of collapse, also called as fish mouth collapse, or we can find lateral collapse at the level of velum. It will help us to decide what kind of surgical options we can consider in those patients. When we negotiate the scope and look at the level of oropharynx, in the oropharynx, the main culprits are hypotropic tonsils. Can you do the jaw thrust for me? And you can see that the tonsils are kissing and making a sound and obstruction. Then the third station is the base of the tongue. Here we are look for the collapsibility. Is it a partial or complete collapse? Is this base tongue is pushing the epiglottis backward, giving you a secondary collapse of the epiglottis? And how much is the contribution? After that, we just do the jaw thrust to see that is this the tongue fall or obstruction is primarily or is because of the jaw. In this video, you can see that tongue-based collapse is significantly improved after jaw thrust, give us an idea about a good candidacy for mandibular advancement device. The last station is epiglottis. Nowadays, around 10% of the obstructive sleep apnea patients have classical epiglottis collapse. This could be a major cause of obstructive sleep apnea or can be the reason for poor compliance with the CPAP. We usually find two types of the collapse. Either it's a trapdoor collapse when the floppy epiglottis hit the posterior wall of the hypopharynx and gives choking sensation to the patient during sleep time. Or second is book type collapse when the lateral collapse. This kind of condition is very difficult to manage surgically. So the understanding about DISE is that all the OSA patient needs to be assessed by the ENT surgeon to check for static as well as dynamic collapse of the upper airway. Those patients having a poor compliance or failure for the CPAP has to be assessed by the ENT surgeon, who can consider DISE. Before offering the surgery for upper airway, one should always consider drug-induced sleep endoscopy as a diagnostic tool. Do not just label vote during the DISE. However, we need to understand the pattern of the collapsibility, behavior of the upper airway mucosa, which significantly help to decide the surgical methodology. So always, decision is very important to make an incision over the patient in obstructive sleep apnea. Thank you very much for your attention.